The following podcast is part of a certified educational activity titled Overcoming Challenges in the Management of Refractory Rheumatoid Arthritis. Expert insight on the clinical potential of novel therapeutic options. Access the entire activity and complete the post-test at peerview.com/XQR860. Downloadable slides and practice aids are also available.
Hello, this is Dr. John Tesser from Midwestern University, Arizona College of Osteopathic Medicine, in Arizona Arthritis and Rheumatology Associates in Phoenix, Arizona. Welcome to this educational activity on rheumatoid arthritis. So as an introduction, let us consider that the most important therapeutic goals for treating RA are eliminating signs and symptoms, such as joint pain, swelling, and stiffness, preventing joint damage or its progression, preventing joint deformity, and maximizing physical function and quality of life. These aims are accomplished by achieving disease remission, a state in which no or only minimal residual inflammation is discernible. Today, this goal is attainable in perhaps up to 50% of patients with rheumatoid arthritis using approved drugs and a treat-to-target strategy. Therapies are modified until remission is reached, providing a strategic approach towards optimizing outcomes for patients with rheumatoid arthritis. Now, of course, we attempt to achieve remission, and if we cannot, we look towards the goal of as low disease activity as possible. So what is refractory RA? I think we all have had some understanding by Gestalt what this means. Now, prior to the introduction of biologic disease-modifying anti-rheumatic drugs, or DMARDs, refractory RA denoted multiple conventional synthetic DMARD failure, although methotrexate inadequate response, randomized clinical controlled trials have historically not mandated the failure to optimal dose methotrexate. This is something that most of us have been knowing. With the escalation to tumor necrosis factor inhibitors as the first available biologic DMARD class, a subsequent multiple TNF-IR failure cohort has emerged. We now observe a cohort that has failed several biologic DMARD classes. The vast proportion, over 70%, of patients on a second biologic DMARD class fail to actually derive a meaningful clinical response. Now, a proposed overarching definition of refractory RA disease on a generic level would be defined as a patient who has resistance to multiple therapeutic drugs with different structures and mechanisms of action. So we would tend, therefore, to think after someone has found inefficacy or intolerability with methotrexate, a refractory patient's disease would be that which has failed at least one anti-cytokine treatment, including an anti-TNF and/or an anti-IL-6 directed treatment, and then a treatment that targets at least one cell mechanism. That could include a B-cell depletion drug and/or a T-cell co-stimulation blockade drug. Since the advent of small targeted JAK inhibitors on the market, we now add some complexity to this, understanding refractory RA, and we may then add refractory disease to include at least failure to one small targeted synthetic therapy. Now, there may be a number of possible pathophysiologic bases for refractory disease. The first may be that a patient's disease is just intrinsically refractory. Following that, the particular drug may be targeting the wrong target in that particular patient. Now, that may be true from the outset of a treatment, and/or it might develop with the subsequent progression of the patient's disease or the addition of other therapies. Perhaps there's refractoriness in any individual patient to either their innate or their adaptive immune systems. There's been some thought of defining this or labeling this by patients whose myeloid system remains active or their lymphoid-driven system may remain active, the former indicating innate mechanism and the latter suggesting it's an adaptive mechanism that is resistant Following this consideration, we may have autoimmunity versus autoinflammation. And these may be distinct or coexistent pathologies that may be driving any particular person's disease state. It may be a stromal response problem, which is a tissue response issue. And then there may be issues of pharmacokinetic refractory disease. This could include the development such as anti-drug antibodies as an example. And this may be something that may spiral on successive use of medicines or biologics of the same category, or perhaps of even additional categories. Then there may be the false positive situation, where the patient's symptoms, their global scores, their pain scores, may be driven by not their autoimmune or inflammatory systems, but perhaps by other factors such as biomechanical pain due to degenerative disease, soft tissue factors surrounding the joint, or perhaps central sensitization processes. If we take a look at categorizing individual and successive refractory drug responses, we can look at primary or secondary onset of presentation, and then see on the left persistent inflammation without anti-drug antibodies, or in the middle, persistent inflammation with anti-drug antibodies present. Of course, the drug won't work in that situation. Or there may be neither of those things, in which we have that false positive situation where other non-inflammatory and immune mechanisms may be at play. Intrinsic refractory, PK refractory, or false positive refractory could actually combine together to not allow any successive targeted treatments to fully work or work at all. And then we are left with a multiple intrinsic refractory patient and/or a mixed intrinsic and PK refractory patient and/or a multiple PK refractory patient. On the right side was that potentially very stubborn situation where there may be a multiple false positive refractory situation, and it really demands that each patient is looked at individually for the potential of these non-inflammatory and immunologic mechanisms that are driving patients' pain and global responses. A timeline of the development of drugs for rheumatoid arthritis, just on the surface of it, demonstrates an amazing array of medicines that have been developed and approved and put on the market over the last 30 years. Here's a table looking at a variety of biosimilars that have been approved since 2016. However, only several have actually been put on the market, and to date in the United States, these agents have had a small impact on the biologic market in general, but these are due to not the intrinsic issues related to these agents, but more to market forces and other difficulties in these agents getting traction in the market as we have. Now, if we take a look at the basic pathophysiology of rheumatoid arthritis, this cartoon attempts to give an overarching review of the immune status and the pathophysiology as we understand it. But if we start at the top, we see an antigen-presenting cell on the left, which is interacting and presenting an antigen to a T cell on the right. It does so through the MHC and T cell receptor mechanism, and we see that there is a CD80-86 interaction with the T cell receptor, which by offering this stimulus 2 or signal 2 to signal 1 MHC TCR, we can see how the T cell now can become activated, and signaling can now work downstream. From the T cell on the right, we see that via a variety of cytokines that are bathing it, the T cell now can be activated and differentiated in the middle of the slide to a Th1 or a Th17, and not shown a Th2, activated inflammatory cell. This can interact with B cell receptors of the B cell on the right, and we can see that the B cell can be driven into differentiating into a plasma autoantibody producing cell. We can see that anti-CD20 drugs can block this interaction and downregulate the effect of B-cell stimulation and thereby the production of autoantibodies. Now, if we turn attention to the T-cell and macrophage interactions, we can see that those are bathed with various interleukins, and the interaction is something that can be blocked by abatacept as well. Abatacept has this ability to block the second signal between these cellular systems. Once the macrophage is activated, it has now the capability of being affected by tumor necrosis factor, interleukin-1 and interleukin-6. Of course, by blocking each of these respective cytokines, TNF inhibitors and IL-6 inhibitors can have a downstream regulatory effect on the ability of macrophages to stimulate synovial fibroblasts, which are significant in terms of their ability to produce and release injurious enzymes like matrix metalloproteinases that can degrade cartilage, and for their ability to stimulate osteoclasts via the production of rank ligand. Because JAK inhibitors go into all cells as they are small molecules, all cytokine messaging through the interior of cells and their respective JAK-STAT systems can be downregulated by these JAK inhibitors. So the entire system can, in effect, have a brake put on it when JAK inhibitors are applied. And this is very important in terms of a more protean effect of JAK inhibitors on all of these systems. Now we're going to focus on several mechanisms of action that have led to the discovery and to the approval of newer medicines by the FDA on two of the systems that have come into current interest. The first system is the interleukin-6 system. We know that persistently elevated interleukin-6 levels play a very important role in the systemic and local effects of rheumatoid arthritis. There's an effect metabolically on lipid metabolism through adipose tissue cell functions. We also know that there's systemic inflammation with IL-6 affects directly on hepatocytes in the liver that will stimulate those hepatocytes to make serum amyloid A protein and C-reactive protein, both very inflammatory molecules. CRP directly goes into the systemic inflammation. We know that it has associated risk factor for cardiovascular disease. It directly has an effect in arterial walls on cholesterol plaques, and it can cause vascular endothelial dysfunction in terms of elasticity and stiffness. There is an effect of IL-6 inducing hypophoремia through the production and release of hepcidin. This is a potential cause of anemia, and then we have effects on osteoclastic activation. IL-6 directly stimulates pre-osteoclasts to mature into osteoclasts to cause bone resorption, and also there is a general systemic loss of bone density leading to systemic osteoporosis, but also juxta-articular osteoporosis and bone erosions around the joint area. Let's translate this into human clinical studies. There is a very well-known ADACTA study, which was head-to-head comparison of Tocilizumab, an IL-6 receptor antagonist, versus Adalimumab, a straightforward classic TNF inhibitor, monoclonal antibody. In this study, patients who were refractory to methotrexate were randomized to receive Tocilizumab at 8 milligrams per kilogram IV every 4 weeks against Adalimumab 40 milligrams sub-Q every 2 weeks. Each arm of patient received placebo, IV, or sub-Q treatment to keep a blind going. At 24 weeks, patients were evaluated for change in DAS 28. There was a 8-week safety follow-up after that, and you can see there was an escape arm that was allowed. But when the intent to treat analysis was done, we can see that over the 24 weeks that Tocilizumab fared better than Adalimumab in the reducing the DAS 28 SED rate ITT population. A MONARCH study was another look at a different agent, which was an IL-6 receptor inhibitor, Sarilumab, versus Adalimumab, in a similar head-to-head protocol design study. These patients had, as the other patients, active rheumatoid arthritis with high disease counts and high DOS 28 SED rate disease activity levels, and they had been methotrexate failures in terms of response, and they were allocated by randomization to receive Sarilumab sub-Q every 2 weeks or Adalimumab 40 milligrams every 2 weeks in an ongoing basis for 24 weeks. Now, the results here are listed both for DOS-28 SED rate and DOS-28 CRP. And this corroborated what was seen in the ADACTA study, that the IL-6 inhibition mechanism seemed to fare better in terms of clinical response for both these measures that were looked at in the Sarilumab 200 milligram every 2 week sub-Q patient population. So it's corroborating this idea that monotherapy IL-6 inhibition may be a superior way to go than using TNF inhibition. If we take now a dive into intracellular signaling, we're calling up the cell surface here, and we can see from left to right, we're looking at a variety of different intracellular signaling mechanisms. Intracellularly, we see that there are a variety of secondary and even tertiary signaling systems by which a signal, which is delivered by a cytokine outside of the cell when it docks to the cell, its cell receptor, will cause a cascade of intracellular enzymatic systems to activate to deliver a message to the nucleus of the cell. And we have to keep in mind what the goal is here. This signal, delivered by a cytokine through its receptor and then its intracellular signaling cascade systems, is attempting to deliver a signal to the operator in the DNA to cause activation of the DNA's machinery to produce further proteins, in this case inflammatory cytokines, to continue to drive the inflammatory system, in this case rheumatoid arthritis. If we take a deeper dive into the JAK-STAT signaling pathway, we can see that there are two types or categories of cytokine signals that we are looking at. And they're divided by their receptors, type 1 cytokine receptor versus type 2. You can see that each of these cytokine receptors have a group of cytokines that can signal them, and there are different categories of interleukins or growth factors. If you take a look into the cell itself, you'll see that there are a variety of JAK pairings that occur. JAK1, JAK3, or JAK1, JAK2. There are 4 JAKs, so there's JAK1, 2, 3, and TYK2. And you will see different pairings are occurring depending on the cytokine and receptors that are signaling these systems. Further down from the JAKs, you'll see that there are STAT pairings that are noted to be occurring. So we have JAK pairings, 1, 2, 3, and TYK2, and there are STAT pairings. There are 7 STATs, STAT 1, 2, 3, 4, 5A and B, and STAT 6. So different STAT pairings will line up with different JAK pairings that will in turn line up with different cytokines and their receptors. JAK inhibition is achieved through a very elegant mechanism. Here we can see a cell surface with a cytokine in orange that is docked with its receptor that is attached to the membrane of the cell. JAK molecules themselves sit on the tails of those receptors. The JAKs themselves are important because they are phosphorylated by ATP. ATP deliver the energy sources of phosphate molecules to the JAKs to allow them to phosphorylate each other. JAKs in turn will then activate the tails of the receptors by phosphorylation with more ATP. JAKs now will then activate STATs when they dock onto the tails of these receptors. Then the STATs will be activated by phosphorylation by the JAKs. They will leave this complex, dimerize, and in their activated phosphorylated state, they will transmigrate to the nucleus where they will activate very specific parts of the nucleus for transcription and then for protein production and then release through the cell into the milieu. And these proteins are these inflammatory cytokines. JAK inhibitors, denoted by these darker blue molecules that are attaching to the JAKs, are small, elegantly designed molecules that are reversibly sit in the groove of the JAKs where the ATP molecules would otherwise attach. With the JAKs sitting there, ATP cannot deliver the phosphate molecule necessary for phosphorylation and thereby energy activation of the JAKs. The entire system is now braked for as long as the JAK inhibitor sits there. And this is the beauty of the system. The JAK inhibitors that are now in use only sit there for a very short period of time, usually between 1 and 3 hours. So this reversible inhibition then allows the JAK inhibitor to unbind from those pockets and leave the cell. ATP now can follow by moving into the pocket and upregulating that whole process. But because the JAK inhibitors are there for part of the time, in any 24-hour period of time, the entire system has been braked, and thereby there's a downregulation, in this case, of RA activation and RA inflammation. Why do we need JAK inhibitors in the RA treatment landscape? Well, although we have these very effective biologic agents and other small molecules, we actually only achieve complete remission in maybe 30% of people with this disease. And the majority of patients treated with biologics will experience disease exacerbation following cessation of treatment. Also, the route of administration is an important consideration. A lot of patients would rather not take their biologic medicine IV or subcutaneously. Consequently, there is a preference for an oral therapy over a parenteral therapy and delivery of medications. Given that we've now identified that the JAK-STAT signaling system is extremely important in RA and other autoimmune conditions, small molecular JAK inhibitors have been proposed as being a very important addition and alternative to biologic therapies for the treatment of rheumatoid arthritis and other inflammatory conditions. To date, we have 2 small targeted JAK inhibitors that have been approved by the FDA. Tofacitinib was approved in 2012 and Baricitinib in 2018. They both have been approved to treat adult patients with moderate to severely active rheumatoid arthritis, but Tofa has been approved to treat patients who have had an inadequate response to methotrexate or other conventional DMARDs, and it can be used with or without methotrexate and such medications, although not with biologic DMARDs. Baricitinib has been approved after patients have experienced a TNF failure, which presumably means they've already tried and not done well enough on methotrexate. They have similar adverse effect profiles, although Baricitinib has shingles that has been called into its own account. The evidence that led to the approval of Tofacitinib is seen here in this table, and one can see that the populations in this table included methotrexate IR, conventional DMARD IR, early RA patients, late disease RA patients, and patients who have had an inadequate response to TNF. And similarly, for the Baricitinib program, there were early disease patients, later disease patients who had not responded to either conventional DMARDs, including methotrexate, and a population that had not responded to TNF inhibition. But it was the population that had not responded to TNF inhibition that was singled out and for which this drug received its indication and labeling by the FDA to be put on the market. The outcome results were the same as before, ACR20 response criteria at 12 weeks, actually earlier time point than the TOFA program for the most part. But it is important to note there are 3 other JAK inhibitors that are closing in on approval. The first one that would get approval the most quickly would be the one at the bottom, Upadacitinib. It's in the phase 3 SELECT program. Pathophysiologic phase 3 RAJ program, and filgotinib, also in phase 3, the FINCH program. Now, there are other agents that are on the horizon for the development of the treatment of the disease. There is a new IL-6 inhibitor that is in phase 3 development, which is different than the other two that are on market. And we have 3 anti-granulocyte monocyte colony stimulating factor agents, which are in their phase 2 developmental programs for the treatment of the disease. All of them are monoclonal antibodies. Now, when we look at all of these agents, we need to keep our eye on the larger consideration of what we're attempting to do when we treat patients. We want to affect patients' prognosis, certainly to have the outlook look more positive. We're looking at their treatment experience, their treatment goals, insurance coverage, which is a huge issue, access to medicines. We could have the best drug in the world, but if patients can't get it, it's not such a great agent. Certainly, we take a look at the risks versus the benefits of treatments and comorbidities. If we take a look at the paradigm by ACR treatment recommendations, we can see that if we start with a patient with early disease, we can identify either low disease activity or high or moderate disease activity, start patients on a monotherapy program, usually methotrexate. If it doesn't work, at that point, you can combine conventional DMARDs, you can add a TNF biologic, or you can use a non-TNF biologic agent. And if after assessing response, the patient is not at goal, you would mix it up and you would go to the next guideline in terms of treatment. And this is outlining what you would do for a patient with established disease who have tried either starting out with moderate or low disease activity or higher, conventional DMARD monotherapy, and then if not getting anywhere, you would go ahead and start adding a biologic, or either the biologic would be TNF, non-TNF, or in this case, you might add, they call out Tofacitinib. If the patient has been experienced with TNF, it might be Baricitinib. But in any case, you continue to measure the disease, you continue to assess response, and if the patient is not getting to remission or low disease activity, you would then continually migrate your patient's treatment to another agent, switching agent, adding agents. It just keeps following the paradigm from there. There is an interesting study that looked at, is it more cost effective and is it equally effective to, rather than quickly move patients from conventional therapy to a TNF inhibitor, would it be just as good to just combine conventional DMARDs? So this was a British study that looked at 12 months of doing just that. Interestingly enough, the results demonstrated that it didn't matter at the end of a year if patients were advanced in terms of combining further DMARDs or having then given a TNF agent. The outcomes were similar clinically and for less cost. So it does bring one to consider that this may be a valid paradigm to utilize in patients who have not done well on at least methotrexate monotherapy, rather than jumping the gun, so to speak, to biologic agents. What about taking patients off therapy, or at least tapering it? So it has been put forward that, at least by paradigm, tapering should be considered only if patients meet a variety of criteria. First of all, you want to have your patient in a very as low disease as possible state. And you should have the patients in that state of remission or extremely low disease activity for at least 6 months. And at that point, you might consider, if the patient's on stable DMARD treatment and or DMARD biologic treatment over the last 6 months, you might consider either tapering or possibly stopping therapy. But they should not be on concomitant glucocorticoids to be maintaining this remittive state. Now, it has been shown that some patients can successfully taper or even stop their therapy. It has been considered that having the patients in serologic remission, i.e. negative anti-CCP antibodies, maybe presumably anti-RF antibodies, and in a state of deep clinical remission, which may include imaging remission, such as ultrasound or maybe MRI and serum markers, their ability to succeed by tapering and or stopping their therapy might be much enhanced. Both types of studies have been done. Direct DMARD withdrawal or tapering protocols have been looked at, but it is important to inform your patients of doing this, and you should have their buy-in on doing this. Everybody should agree by shared decision-making that there's going to be an attempt on doing this. A lot of us get asked by our patients how long they need to be on their therapy. Is it reasonable at some point to stop their therapy? These are considerations to take into account. It probably is better to taper rather than cold turkey patients from their therapy. This way, you would have a better idea of how the patients would do over time. And this concept would apply both to biologic therapy and synthetic DMARDs. It's important to monitor at regular intervals patients' disease activity, to measure the disease activity, to be able to note very quickly if there's a relapse, and then to institute therapy again, reinstitute it, to try and regain capture of the disease. Many studies have demonstrated that if this is done carefully and quickly, that if you reintroduce therapy, you're able to recapture the disease activity such that the patient's disease doesn't gallop on to uncontrolled situations. This is a schema to consider active disease to remission. One thought, first of all, is the thought of debulking inflammatory disease. And you can see through the stepwise progression of the little colored boxes that by instituting DMARDs, one could take patients from high disease activity towards remission by DMARDs, and thereby debulking the gross inflammation that may be present and clinically obvious. But to get to real remission, you might think of it in several different categories. On the far right, it's probable that probably 80 to 90% plus of patients who have achieved a clinical remission and have their medicines removed, they will have a relapse. If, on the other hand, you have a clinical remission and then an immunologic and an ultrasensitive imaging remission, that maybe those patients have a better chance of not relapsing, but there is probably a significant chance of relapse, denoting by that non-bolded arrow going from the middle of that middle box towards relapse. Imaging would include not just radiographic images. They are not able to identify inflammatory activity in either synovium or within the bone, such as osteitis. But more sensitive imaging parameters can, such as ultrasound and MRI. And then you can see a patient who's in far left immunologic remission, that they might still relapse, but their chance will be less than if they're in the other two clinical and serologic states. So when we think about doing these kinds of things, the principles of treating to target come up. Measure the disease activity, adjust therapy accordingly. This will allow for better patient outcomes. The primary target should always be clinical remission. No signs and symptoms of significant inflammatory disease activity. Is it always possible to get patients into remission, and even clinical remission? And that's not true, obviously. It's very difficult. So in some patients, low disease activity may be the best we can get, and it may have to be an acceptable treatment goal, especially with patients with long-standing established disease, and especially in patients who have been refractory, as we explored before, who have not responded or failed multiple drugs of multiple classes and mechanisms of action. What should constitute the remission target? Well, it may not just be the clinical remission, and it may not just be preventing joint damage and disability, but the thought comes up, maybe it's getting patients to have no subclinical disease activity. And that would be assessed, presumably, by the concept I mentioned before, more ultra-sensitive imaging techniques, ultrasound and MRI. So there are two prospective trials that explored this. One was known as the TASER trial. It took a population of rheumatoid arthritis patients, and it looked at patients who were treated according to their clinical measurements by DAS28 SED rate, or who were treated according to their Doppler joint counts by a musculoskeletal ultrasound. At the end of 18 months, you can see, though, that by clinical measures, DAS44 in the left graph, ACR 20, 50, and 70% responses in the middle graph, and by high hurdle responses, DAS44 remission, or ACR EULAR remittive status on the right graph, there was really no difference between these treatment strategies. In fact, the p-values were not statistically significantly different. The Doppler group had more treatment changes, and for both groups not shown on the slide, there were no radiographic differences or MRI differences for osteitis and synovitis scores at the end of the 18-month treatment period. And that's the conclusion. An ultrasound-driven strategy for treat to target did not lead to significantly better clinical or imaging outcomes. This concept was further demonstrated in the IMAGINE trial. This trial was set up in a similar fashion. One group was having their disease treatments changed by an MRI-guided treat-to-target strategy, and the other by clinical disease treat-to-target strategy. And to look at the table, the difference between the clinical and the radiographic groups in the far left by rows showed that the percent of patients who hit the primary endpoint of DAS28 CRP or no radiographic progression was no different by p-values. The one thing that was demonstrated is that the patients who had their treatment changes driven by imaging had more intensification and changes done to achieve these similar outcomes. The findings, therefore, do not support the use of an MR-guided strategy for patients who are being treated with RA, just as the ultrasound-guided strategy was not found to be more useful in the previous TASER study. So we come to some conclusions about all of this. Parameters have been identified by which we can understand what constitutes the medication refractory patient. And as we better understand the pathophysiology of a very complicated disease, more therapeutic targets have been identified. The newer ones in particular are called out, interleukin-6 and the JAK-STAT pathway. And even more agents with novel mechanisms of action are on the horizon. And that current guidelines and evidence recommends its stepwise progression for RA treatment, starting with DMARD monotherapy, the gold standard being methotrexate, that then can be logically moved on to combination therapy, either using conventional DMARDs, and there's some evidence to suggest this may be a better strategy, at least for cost containment, and to avoid biologic therapies, at least in one study. Further analysis should be done. And then moving on to targeted biologic agents and/or small targeted molecules, and that it's critical to optimize methotrexate before doing this escalation and switching therapies. Tapering may be possible for certain patients, but it must be done with caution and strategically. Best to start with patients who are in deep remission, clinical remission, sustained remission, probably immunologic remission or serologic remission, and stopping DMARDs is probably not a good idea in most patients, and this is actually by guidelines too. Current evidence now shows that using very sensitive imaging to drive therapy and outcomes is probably not necessary. They certainly have the utility for diagnostic purposes, for demonstrating improvements, but for getting ultimate therapeutic targets in terms of remission may be not necessary. And overriding goal of understanding that clinical remission or the lowest possible disease activity status is best for our patients with rheumatoid arthritis is still a driving clinical concept.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/XQR860. This activity is supported by an educational grant from Lilly. For further information concerning Lilly grant funding, visit www.lillygrantoffice.com. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.